Welcome to the 10-Minute Medic, the podcast where we take 10 minutes to look at and review one medical topic. I'm your host, Dr. Bill Young. This topic will cover a multi-week review of the pathophysiology of shock. This is an incredibly important topic that EMS responders need to be an expert level because when it happens, it can spiral out of control quickly. Now, we need to begin with some definitions. First, exactly what is shock? Well, shock is a critical condition characterized by a state of cellular and tissue hypoxia resulting from various underlying pathophysiological mechanisms. It can occur when there's a significant mismatch between the oxygen delivery and oxygen consumption within the body's tissues. The primary causes of shock can be categorized into reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization, or a combination of all of these. Each type of shock presents with distinct pathophysiological features, yet they all accumulate in impaired cellular metabolism and organ dysfunction. Within reduced oxygen delivery, when we see this within hypovolemic shock, this type occurs due to a significant loss of intravascular volume, such as seen as in hemorrhage or severe dehydration. The reduction in blood volume leads to decreased venous return, lowered cardiac output, and ultimately diminished oxygen delivery to the tissues. In cardiogenic shock, this comes about from the failure of the heart to pump effectively, often due to myocardial infarction, arrhythmias, or cardiac myopathy. The reduced cardiac output impairs systemic perfusion as well as oxygen delivery. In distributive shock, this is commonly seen in sepsis, anaphylaxis, or neurogenic shock where there's widespread vasodilation and redistribution of blood flow away from vital organs. Despite normal or increased cardiac output, this maldistribution results in insufficient oxygen delivery at the cellular level. What about increased oxygen consumption? In septic shock, this is characterized by an overwhelming infection that leads to a hypermetabolic state where tissues have a massively increased demand for oxygen. The inflammatory response causes cellular dysfunction and increases O2 consumption, further worsening the mismatch between supply and demand. In severe trauma or extensive burns, the body's metabolic rate spikes due to the stress response, increasing the demand for oxygen and nutrients, in particular glucose, to support tissue repair and immune function. How about inadequate oxygen utilization? Conditions such as sepsis can impair the mitochondrial function, reducing the cell's ability to utilize oxygen effectively, even when oxygen delivery is more than adequate. This leads to cellular energy failure and contributes to multi-organ dysfunction as seen in shock. In many cases, shock results from a combination of all of the mechanisms that I just talked about. For instance, septic shock involves both distributive and cardiogenic components alongside increased oxygen consumption. The complexity of shock necessitates a thorough understanding of these overlapping physiological processes to guide effective treatment strategies by you, the paramedic. At the cellular level, inadequate oxygenation leads to a shift from aerobic to anaerobic metabolism, resulting in the accumulation of lactic acid and metabolic acidosis. Energy depletion impairs cellular functions, causing ion pump failure, cellular swelling, and eventually the cells rupture and they die. Systematically, prolonged shock can lead to multi-organ failure, with the most vulnerable organs being the kidney, the liver, the heart, and the brain. Understanding the multifaceted pathophysiology of shock is crucial for timely diagnosis and intervention by the paramedic. Effective management strategies aim to restore adequate oxygen delivery, support cellular metabolism, and address the underlying cause to improve patient outcomes. So first, let's get the parts in place. Let's talk about the heart. The heart's ability to function as an effective pump is crucial for maintaining adequate cardiac output and ensuring proper tissue perfusion. If the heart fails to pump effectively, as we see in cardiogenic shock, the reduced cardiac output leads to inadequate oxygen delivery to tissues, resulting in hypoxia at the cellular level and metabolic disturbances. Key aspects to remember about the functioning of the heart include stroke volume. Stroke volume is dependent on preload. Now, preload refers to the degree of stretch of the cardiac muscle at the end of diastole just before contraction. It's primarily determined by the volume of blood returning to the heart and filling the ventricles. We have a reduction in preload. We have a reduction in cardiac output. I like to say that unlike the United States Congress that regularly spends money that it doesn't have, the heart cannot pump out blood that it doesn't have. Preload is influenced by several factors. First of all, venous return. The volume of blood returning to the right atrium from the systemic circuit. Increased venous return elevates preload. It increases that volume. In diastolic volume, the volume of blood in the ventricles at the end of diastole. A higher end diastolic volume indicates higher preload. Ventricular compliance. The ability of the ventricles to stretch and accommodate incoming blood. More compliant ventricles can handle larger volumes, increasing preload without excessive pressure and contractility. Speaking of contractility, also known as inotropy, this refers to the intrinsic ability of cardiac muscle fibers to contract with force and speed, irregardless of what the preload or afterload is. It is a measure of the myocardium's strength and efficiency in pumping blood. By boosting stroke volume, increasing contractility, this leads to higher cardiac output, ensuring better tissue perfusion and oxygen delivery. On the other hand, weaker contractions result in a lower fraction of end diastolic volume being ejective. As a result, it reduces stroke volume and cardiac output. This lower stroke volume, due to impaired contractility, often leads to diminished cardiac output, potentially resulting in inadequate tissue perfusion and organ dysfunction and ultimately death. When we're looking at afterload is the resistance that the left ventricle must overcome to eject blood during systole. It's very similar to your blood pressure. It represents the load against which the heart has to contract to push blood into the aortic as well as the rest of the body. Essentially, afterload can be thought of as the pressure the heart pumps against during ejection. Increased afterload means the heart has to work harder to overcome the pressure in the aorta. This requires greater force and greater energy expenditure. When the afterload is high, the left ventricle may not be able to eject all the blood effectively, leading to a reduced stroke volume and reduced cardiac output. Decreased stroke volume due to high afterload, again, reduces your cardiac output. What about decreased afterload? Well, decreased afterload means that there's less resistance for the heart to overcome during systole. With lower afterload, the heart can eject more blood more easily, increasing stroke volume. Increased stroke volume enhances cardiac output, improving tissue perfusion and reducing the workload of the heart. Let's talk about heart rate. Heart rate definitely has an impact on the cardiac output, with both bradycardia and tachycardia impacting perfusion efficiency. Increasing the heart rate increases cardiac output as more beats per minute result in more frequent ejection of blood. The problem is extremely high heart rates, greater than 150, can reduce diastolic filling time, potentially reducing stroke volume and thus diminishing overall cardiac output. At the other end of the extreme, decreased heart rate generally reduces cardiac output, as fewer beats per minute mean less frequent ejection of the blood. To compensate for this, stroke volume may increase, particularly in well-conditioned athletes with lower resting heart rates. In cardiogenic shock, myocardial infarction, severe arrhythmias, or cardiac myopathies, all of these can compromise your cardiac output. Reduction of cardiac output leads to systemic hypoperfusion, worsening hypoxia at the cellular level, and ultimately leading into death. We also have to have an adequate blood volume. Adequate blood volume is essential for maintaining venous return and cardiac output. This blood volume encompasses multiple factors. First of all, oxygen diffusion into the blood. Adequate ventilation and diffusion across the alveolar or capillary membrane are required for efficient oxygen uptake. Conditions like acute respiratory distress syndrome or severe pneumonia impair oxygen diffusion, contributing to hypoxic shock. We got to have plenty of red blood cells to flow around the alveoli for that gas exchange to take place. Pulmonary embolism or severe pulmonary hypertension can obstruct this flow, reducing oxygenation. Let's not forget about hemoglobin. Hemoglobin is a protein that carries oxygen. For every molecule of hemoglobin you have, it will carry 4 molecules of oxygen. When your patient's anemic, it reduces the blood oxygen carrying capacity. Severe anemia can precipitate hypoxemic shock by limiting oxygen delivery despite normal cardiac output and perfusion levels. Hemoglobin's affinity for oxygen is influenced by the blood pH. Metabolic acidosis or alkalosis, hypothermia, can alter hemoglobin's oxygen binding affinity, releasing that oxygen and not making it available now for the body's. The integrity of the vascular system is vital for maintaining blood pressure and effective perfusion. In distributive shock, widespread vasodilation and increased capillary permeability lead to hypotension and inadequate perfusion. In our next session, we'll take a closer look at the more common types of shock. We'll focus in on the pathophysiological effect on the body. Thanks again for joining the 10-Minute Medic.